Hello, my name is Oluwafumilaya Adebayo. I go by Fumi. I have been a nurse now for 11 years. I work in the operating room. I am a perioperative nurse educator. I'm enrolled in the family practice DMP track at Regis College. The problem in my area of practice is inconsistent or non-compliance with the surgical debrief that we are supposed to perform on our patients before they leave the operating room as a safety measure. What is a surgical debrief? As a measure to promote safer surgery, the World Health Organization came up with a surgical safety checklist for all operating rooms. This checklist is widely utilized in many operating rooms around the world. It consists of a sign-in aspect, a timeout, a sign-out also known as a surgical debrief. A timeout, for example, there's a pause. It is initiated by the nurse and conducted by the nurse. The team stops right before incision on the patient. We verify the right patient, the right surgical procedure, right equipment in the room, implants if applicable, and so many other things. The surgical debrief, somewhat similar. However, it is the surgeon briefing us on the actual procedure, telling us, verifying the procedure, verifying wound classification, anesthesia verifying estimated blood loss, verification of specimen, verification of surgical counts. The only difference here is there's no pause, and basically it happens towards the end of the surgery where so many other things are going on. Another difference is that it is initiated and conducted by the surgeon. So therefore, because they're always in a hurry to see the next patient or to go out and dictate, they often forget and get caught up with the so many moving parts in the operating room. What population is affected? The affected population here are the patients, because when surgical errors happen, when miscommunication happen, the ones whose life is altered are the patient, and which can end in like detrimental effects. What interventions am I looking at in this project? And how did I know it was a problem? Yes, our providers mentioned it. Some of our surgical team members did express a need to find a way for us to be better, to be more compliant, just as we are with the surgical timeout. So I thought, since the surgical timeout is led by the nurses, it is more consistent, why not try and see if nurses can also initiate and conduct the surgical debrief? Though they were not the ones who performed the surgery, but they were in this, they are mandated to be in the surgery from beginning to end. They don't leave their patient until the patient gets out of the room, so they might have more success. They will be, with this intervention, we would have an education section to teach these nurses how to lead a surgical debrief, what they should be looking out for. There will be a pre-assessment and a post-assessment before and after this education, and we would have a time period whereby we would have nurses conducting this surgical debrief, and after all, we'd see if our results actually improved. The framework I'm going to be looking at for this implementation will be Patricia Benner's novice to expert theory. Pretty much it is a progression from novice to advanced, beginner to competent. It's more like a learning model. Our nurses are going to be starting as novices to surgical debrief. As they don't perform surgery, they're only supportive aspect of surgery. So the goal is they will be novices in the beginning. Hopefully they would get competent, and their confidence levels will be measured even during this implementation process. Post evaluation intervention would be a survey of how the experience went, how comfortable they were, to assess their confidence level, to see if we can actually continue with this and implement this new change in the facility where this will be going on. I hope I was able to help explain thoroughly. Thank you for your time.